Good afternoon. Welcome to our presentation on same-day total joint replacement. We are going to go ahead and get started. Just a reminder, this presentation is being recorded and the recording will be made available via our website and social media channels within 24 hours after the event. All participants are muted for ease of presentation, but if you have any questions throughout the presentation, we invite you to use the Zoom chat feature to ask. Submit your questions at any time, and we will make sure they are answered during the Q&A portion of the presentation. Now, a brief introduction of Dr. Timothy Krahn. Dr. Krahn is one of our 34 orthopedic surgeons at OrthoSouth. He is fellowship trained with a specialization in sports medicine. He has 25 years of experience and is passionate about caring for patients of all ages with knee and shoulder conditions. Dr. Krahn served as the medical director of Ortho Memphis for over 15 years and as the team doctor for Christian Brothers High School for 21 years. Today, he is here to talk about the benefits and considerations of same-day total joint replacement. With that, take it away, Dr. Krahn.
Is the audio doing okay?
It is.
Okay, great. Well, it is a privilege. I've actually just finished my 27th year with OrthoSouth, initially the orthopedic clinic in Ortho Memphis, and starting my 28th year. No one would have ever dreamed even 5 or 6 years ago of doing a lot of joint replacements as an outpatient. So things have really changed. We're real excited to have everyone here. And like I said, at the end, if they have questions, we'll be glad to answer any questions. I just want to say that I do a lot of dictating. So if I happen to say period at the end of a sentence, it's just part of what I do at work. My wife laughs at me all the time about that. But as we get started, a joint replacement, everyone's heard of hip and knee replacement, shoulder, or even ankle replacements. We're doing this for patients who have an arthritic joint. Arthritis is when the cartilage in the joint will start to deteriorate, and people start to then experience the symptoms of arthritis. The symptoms of arthritis involve pain and discomfort with activity. If you sit for a period of time, you go to get up, you're very stiff, you're very sore. And a lot of times people even have a sense of instability in the shoulder. They have difficulty moving their shoulder. So what arthritis does, it impairs a person's quality of life. They find themselves avoiding, let's say, going to a restaurant or going on a vacation or going to church because they say it's not fun. I don't want to go do something because my knee, my shoulder, my hip hurts. Most of these patients have been dealing with this for years. Some come on fairly quickly. So our focus, our goal through surgery is to improve the quality of life of people who have been experiencing symptoms with arthritis. Before we jump into a joint replacement, though, most of the patients, whether it's through orthopedist or rheumatologist or their primary care doctor, they'll seek non-operative treatment. Non-operative treatment involves medications like Advil or Aleve or prescription anti-inflammatories. If those don't work, a lot of times we'll do cortisone shots. Cortisones can be injected into the joint and they help decrease the inflammation. And a lot of times for 2 or 3 months at a time may help with the pain. With the knees, we can do hyaluronic acid injections, or people hear rooster shots or gel shots. But when it gets to the point when a patient says, nothing is working, I continue to have pain, I continue to have discomfort, my quality of life is such, that's when we're going to say, let's sit down and talk about what we can do from a joint replacement standpoint to make your quality of life better. Go to the next slide, Melissa. So when we do joint replacements, traditionally, up until the last 3 or 4 or 5 years, you would spend 2 or 3 days in the hospital. You'd be check in the morning, do the surgery, and usually spend 2 or 3 days because the pain management may not have been the best, or we worry about blood loss. But with new innovative techniques in anesthesia, blood management, and orthopedics, we've been able to take a significant percentage of these patients that would generally have gone to the hospital, and we're now doing them at an outpatient setting in what we call same-day surgery. Not all patients are going to qualify this, but as we get more into it, I think we're probably seeing 30 to 40% of our patients who we could now do same-day surgery. And I will predict in the next 3 or 4 years, it'll be closer to 60 or 70, even up to 80%. When we look at a patient, we need to make sure they don't have any significant medical issues. If they have ongoing heart disease, or they're morbidly obese, or they have diabetes that may not be in the best control, they should probably be done in the hospital. In addition, you have to have good support at home. You need to have what we call the team leader, the spouse, or a child that's going to help take care of them. We need to be certain that you're going to be able to do everything at home, because for the first 3 or 4 days, you're probably going to need a lot of help. Most of our patients are younger. They have fewer medical problems. But particularly with this COVID crisis, patients are reluctant to go in the hospital. And so in the last 4 weeks, I've done 4 patients over the age of 72 with Medicare, and they have done very well. So we're looking for patients, no matter the age, but healthy patients who are motivated and that want to take control of their own care. Now, one thing I would like to just point out, when we do surgery at the surgery center, we're not saying in this presentation, we're not saying the quality we're provided is any better than the hospital. The hospitals are gold standard. I still do patients at Baptist and Methodist, and they do a phenomenal job. They really are great. The biggest issue is we're trying to provide a better experience. We're trying to provide an experience where the patient's more involved, the family's more involved. So at the end of this day, we're not trying to say we're doing anything better. We're just providing a better experience. And if we feel that you really need to go into the hospital, the care you're going to be provided is going to be equal as to the care we can provide at the surgery center. So what are the benefits? You may say, why would I want to do same-day surgery? In a traditional hospital like Baptist or Methodist or St. Francis, you may be the first case, 7 in the morning. Well, there's probably 20 or 30 people checking in. So you have to get there 2, if not 3 hours in advance. So if you're a 7:15 case, you may need to get there 4:30 or 5. You could be in a long line. In a surgery center, it's more intimate. You're getting there probably no more than an hour in advance. You're not having to get there early. When you get to the surgery center, you're going to be in your own little private room. You're going to have your same nurse in the holding area, and then in the post-op, your own private nurse taking care of you. Hospitals are oftentimes very busy, and so it's not at all uncommon. Once you get to the recovery room, you may spend 2, 3, 4 hours in the recovery room waiting for a bed to be cleaned. So if you spend a lot of time in the recovery room, you may not even be seen by a physical therapist in the morning. At the same-day surgery, whether it's the nurse or the physical therapist, they're going to have you out of bed within 2 hours. They're going to make sure you can get to and from the bathroom. We're going to make sure you're mobile. You're not laying in bed. And at the surgery center, after about 4 to 6 hours, you're heading home. You're going to spend the night in your own bed. Your family's going to take care of you. Currently, most hospitals with the COVID crisis are not letting family members stay with the patient. So you're around your family, your own environment. Whoever's ever spent the night in a hospital, you'll see if you're at night, they come in every 2, 3 hours. It's hard to get a good night's sleep. So same day benefits, it's just more intimate. You're going to have a team that's caring for you, physical therapy that day. And then again, the best aspect is you'll be home that night with your family taking care of you, and you be in the comforts of your own home and bed. So you may say, how do we decide how is this going to happen? When I see a patient in the office and I think you're going to be a candidate, I'm going to approach them. I'm going to say, listen, we've got this new program. It's same-day surgery, and I think you'd be a great candidate. Some patients are maybe a little reluctant. Most people are very excited about it. So we'll talk about it. We'll go through the risks, the benefits. We'll make sure medically that you, I think, are a good candidate. And if that's the case, we will then have our surgery schedules, pick a date, and schedule at one of our surgery centers. I think where we're unique is we have a nurse navigator named Marcia. She's been working with patients for the last 5, 6 years, dealing with total joint patients. She usually works with anywhere from 200 to 300 a year, and she's going to call you. She's going to assist you in getting your medical clearances. She's going to coordinate your pre-op and post-operative therapy. But more importantly, she's going to call and talk with you. She's going to make sure that you have enough help at home. She's going to make sure that your medical condition is good and okay for same-day surgery. Marcia may pick up the phone and say, hey, Dr. Krahn, Miss Jones here. She's a little reluctant, and I'm concerned about some issues. So let's do her in a hospital. So she's the one that would ultimately say, you know, we can do it. So we've got a nurse who literally has probably talked with more than 1,500 or 2,000 patients over the years, who's got great experience that helps us determine whether or not you're ready for same-day surgery. She also will do telemedicine visits after the surgery on days 1 and 2 to make sure you're doing okay. And then part of our program, which we've currently put on hold, and we're going to do a webinar like this, is we used to offer an outpatient joint class that prepared you for surgery. Obviously, we're not trying to get big groups together, so hopefully in the near future, we'll have a seminar like this to educate the patients, because we do think that the most important part of this process is working with the patients and educating them so they know what to expect during the entire process of their surgery. So what can we expect? You're gonna, at the day of surgery, you will show up probably about an hour before surgery. Let's say you're at South Haven, where I do most of my cases. You're gonna get checked in by Amy. Then you'll meet Jennifer. Jennifer's gonna take you to your room. You'll get comfortable, they'll start an IV. And then the anesthesiologist is gonna come in. The anesthesiologist is integral, because the reason we can do this surgery now is we focus on pain management. We're doing everything we can do to manage your pain, and I'm going to talk about some of the techniques. So the anesthesiologist will meet with you. He is going to do a nerve block. The knee and hips are a little different, but they do nerve injections around nerves, which help with post-op pain. The majority of the cases in the lower extremities, the hip and knee and the ankle, are going to be done under spinal anesthetic. Probably 90-95% are done under spinal anesthetic, because all the literature shows this is what's beneficial for joint replacements. In the rare instances, if a person has significant arthritis in their back or they may be on aspirin, we may not be able to do it. But they're going to really help with your pain management. When you go to surgery, whether in a hospital or surgery center, the techniques are the same. But some of the things that we can do now have really improved pain management and blood loss. At surgery, when we're done with the procedure, we'll inject a local anesthetic called Exparil and combine that with a conventional Marcaine, and we'll inject it around the tissue. This will keep your knee basically numb for anywhere from 24 to 36 hours. So that works great. You'll go to the dentist's office, you leave, your mouth is numb for 2 or 3 hours. Well, this will keep your joint numb, hopefully for 24 to 36 hours. There's a newer medicine called tranexamic acid, or TXA. It's given to you intravenously. You don't know it, but it also dramatically decreases blood loss. So 4 or 5 years ago, we would put drains and have to leave them in for 24 to 48 hours in the joints. Nowadays, because the blood loss is significantly less, we don't have to do that. So with those 2 different medications, which are given in the operating room, it allows us to avoid drains, and it helps with pain management, so we can get you home the same day. Once you leave the operating room, you're going to go to the recovery room. Both of our centers have dedicated recovery rooms. You'll have the same nurse that you had preoperatively, so you're going to be comfortable with that nurse. The spinal anesthetic typically takes an hour or 2 to wear off, so when you wake up, you won't be able to move your toes or your feet. That's kind of disconcerting to some of our patients. But within an hour or 2, your spinal anesthetic is wearing off, the local anesthetic, your knee is kicked in, and so they're going to get you up. Literally, within an hour or 2, you'll walk to the bathroom, you'll walk around the center. We're going to make sure you can void. And so you're going to be comfortable when you're leaving. You'll actually go home within about 6 hours from the time you checked in, maybe a little sooner, maybe a little later. If we need, Marcia can arrange for a physical therapist to meet you at home that afternoon if you're uncomfortable with getting the patient into the house. You, with either my assistant or Marcia, will arrange physical therapy. That usually starts the day after surgery. In my case, I use a CPM machine, so that'll come home with you. And then Marcia will check up with you, including telemedicine visits. And more importantly, when you leave the center, and I think all the doctors in our group do it, you'll have my personal cell phone number. So all of us want us to know we're in this with you. And I tell my patients, I don't care when you call me 24/7, you've got my cell phone number. I don't want you calling the doctor on call. You call me. Any problems at the pharmacy, you forget some of the instructions, call me. We spend a significant amount of time with the family, good 10 or 15 minutes. We have pre-printed instructions that are very detailed that go over the pain management, how we do things with scheduled medicines and breakthrough medicines, dressing changes, CPM parameters, PT, everything, it's all written out, and we'll spend time with the family member. In the recovery room, we'll provide the family either a gift certificate for Nukes or Chick-fil-A, or at the Germantown, we'll provide you lunch so the patients can have lunch. At the Germantown location, we can get your prescriptions filled and you can go home with them. You won't even have to go by the pharmacy. We're working that at South Haven. But so see, these are some of the benefits of doing it at an outpatient center to where you can just go home and be at the comforts of your house that evening. So you may say, why us? You know, we're not the only group in town, but I do think we provide a very unique experience. The doctors are very open about this. We're working with the patients. We provide our cell numbers. Having nurse navigators, Marcia and her assistants, to me is really key. They've got such a great experience in working with patients, and they're going to talk with you. I think after you, every patient that's scheduled for same-day surgery will talk with one of our nurse navigators, and you're going to find just a comfort level of knowing you're talking with someone who has done this, and they can talk you through it. If you have questions, concerns, a lot of times you don't think about questions when you're visiting with the doctor. You can answer, Marshall will answer these. They'll work with the insurance company and make sure you get personalized care. Now, as we talk about outpatient joint replacements, Memphis insurers have been very proactive. They like it. And so we can do outpatient joints on patients with Cigna, United Healthcare, Humana, Aetna, and Blue Cross Blue Shield. From a Medicare standpoint, Medicare does allow total knee replacements to be done in an outpatient setting. The hips are on the investigational list. We anticipate in 2021 that hips will be done as an outpatient. The shoulders are still not really even been looked at. So if you happen to have Medicare in 2020, your joint can be done from a knee replacement standpoint outpatient. Hips still have to be done in the hospital, but by 2021, we think that will be approved. Since we started, we've had no infections. A couple of weeks ago, I did have one patient we thought was infected, did not turn out to have an infection. So we've been very successful. We've done over 300 joints between the two centers over the last couple of years and have had very little complications. We've not had to admit any patients into the hospital for pain management. We had one patient, for whatever reason, the nerve block took almost 24 hours. The spinal took 24 hours to wear off. So we just put them in hospital observation and they went home the same day. And so we feel like we provide an excellent experience. Literature over the last 12 months has shown that patients with same-day surgery actually tend to do better. And we think it's not because the care is so much better, but it's because these patients are motivated and they've actually chosen to be more involved in their care. And if a patient is educated and works with the team and they're taking onus on their own care, they're going to do better. Now, obviously, COVID has consumed our lives, and we're all concerned about it. Patients come in and ask us about COVID. We can't guarantee we provide a perfect environment, but we're the only surgery center in the Mid-South that currently tests all employees and the patients for COVID. From an employee standpoint, the doctors and nurses, everyone in the surgery center, including the representatives, we were tested in end of May, early mid-May. And we retest, 10% retest every week. So I just got my second test last week. So in a 6 to 7 week period, we're going to retest them. Employees, when they come into the surgery center, we check their temperatures. Obviously, it's an intimate center, and we can see if people have any type of symptoms. So we are testing all the employees. As a patient, we will test you 3 days before your surgery. The results come in within 48 hours. Obviously, if by chance you happen to be infected, you don't want to have surgery. Since early May, when we started surgery again, we've tested and had 4 people that actually tested positive who had absolutely no symptoms. And we're able to prevent them from presenting to the surgery center and potentially infecting the employees and our other patients because we did test them. Again, all of us are going to be retested 10% each week randomly. Same thing with our physical therapist. Obviously, you're going to go to a physical therapy center. They're tested, and every 10% are retested. So we're doing everything we can do to provide a safe environment. And as I stated, all the surgery patients, if you're any patient, even from a nerve block to a total joint to a routine knee arthroscopy, all patients in our surgery center are tested 3 days prior to surgery. And then patients ask, should I wait till the COVID crisis is over? Honestly, I don't think anyone knows when this is going to be over. Probably not till a vaccine is available. We had a period in the end of March through early May that we had 6 to 7 weeks we couldn't do surgery. And I think we're all concerned as the counts rise. There may be in the near future a time that we can't do surgery again. We don't know that. So if a person asks me this question, I'll say, do you think you can live with your joint, your knee or your hip for another year, year and a half? Because it's probably going to be that long. do it. If on the other hand, you think, no, my quality of life, I really need to do something now, I think now's the time to do it. We're doing everything we can do to protect the patient. And so it's just a personal decision the patient will make with their family and their doctor. So we've got a bunch of doctors, Dr. Tabor, Dr. Ferguson, Dr. Wadowski, Dr. Samar, Dr. Neal, Dr. Patterson, myself, Tom Gill, and Steve Wagner. These are the guys in our group that do most of the joint replacements. If you see any of them, talk to them, say, hey, what is this? What is same-day surgery? Do you think I'd be a candidate? If so, let the nurse navigator walk you through the process. If you have any questions, again, the nurse navigator can work with you. And I think most of us will even defer to Marcia. If we say, I think you're a great candidate for same-day surgery, and Marcia says no, we're going to listen to Marcia. We have that much respect for her, and she will be a tool or asset as you go through this process and try to decide if this is best for you. So if you're interested, call us. There's our phone number. Ask for an appointment. You can book online or you can email us. The most important thing is all of us have come together, and we want this to be a process when the doctors, Marcia, our assistants, you and your family feel like a team. We want to take you from the initial visit, from the time you meet me or one of the other doctors, to your pre-op visits, your post-op visits, your inter-op, and even till you're totally discharged from our care. We want you to feel that we're working with you, and by you taking control of your own care, there's no question, I think everything should come out better.
All right, and that we are ready to move into our question and answer portion of the presentation. And I do have one question right away. Dr. Krahn, if you have an older partial knee replacement and now you need a full knee, you still be eligible for the same-day surgery?
In most cases, with a total knee replacement, a conversion of a partial knee replacement to a total knee replacement, it's a little bit more difficult, and sometimes you have to use revision implants, and so it'd be a case-by-case basis. But to answer your question, the majority of them could be done in a surgery center.
Thank you, Dr. Krahn. If anyone else has a question they'd like to ask, I'm getting some more here. This person says, I have a deformed hip due to leg Perthes.
Leg Perthes disease, correct?
Okay. Are hip replacements under review?
Basically with a hip deformity with Perthes disease, that oftentimes leads to an arthritic joint. So the first thing you'd want to do is see one of the doctors in our group that does hip replacements, let them x-ray you, review the x-rays with you, and then they can, without seeing x-rays, it's hard to necessarily say what's the best treatment. But the first thing and the best thing you could do is meet with one of our doctors, let them x-ray you, and let them give you advice as the best way to treat your hip.
Thank you. Our next question is, what is the total expected recovery time?
When you say total expected recovery time, I kind of break it down into stages. When a person says, when am I going to feel like my normal self and I can return to my normal activities, it's generally about 3 months. During the first 2 to 3 months, you're tired, you don't sleep well, anytime you have a major surgery. So by 3 months, almost everyone has returned to full duty work. People are walking around saying, my knee feels much better, I'm sleeping well, my energy level is better, I feel like more normal self. So at 3 months, people are back to where they were before surgery, but they still know they have a hip or knee. Full recovery, it really takes almost a year. And so typically at 3 months, they're much better off, but it'll be 9 months to a year. And at that point, they'll say, I didn't even think about my hip. I didn't think about my knee. This is really great. So the long term, you'll see improvement for a whole year.
Here's another question, and I've actually got a few of these. What is the recommendation on having both knees operated on at one time or at the same surgery?
Well, yeah, and that would be not realistic at a surgery center, just because it's just too much surgery for one. The decision to do bilateral, which means both sides, is based on really the patient's health, the patient's age, weight, what their motivation is. So it's a decision you have to make. We do quite a few in the hospital. And usually those have to stay a day or two, and probably 50% of patients who have both their knees done will end up going to a rehab facility or skilled nursing facility. And that's kind of, since the COVID crisis, we've not done any, I haven't done any bilaterals, because if there's a chance a person has to go to a rehab or skilled nursing facility, those right now are sort of a high risk, and most patients aren't really wanting to do that. So if a person really wants to do bilateral and they're motivated and they're healthy and they have help at home, they could certainly go home. But again, most of the time we're going to do those in the hospital because it's just too much surgery, and we want to make sure after a day or two they're good enough to go home from from a PT therapy standpoint.
Excellent, thank you. Another question, is there any other condition other than arthritis that would require a joint replacement, such as a stress fracture in the knee?
Well, a stress fracture, we see people all the time with stress fractures. And if they heal, if I saw a gentleman today who had a subchondral stress fracture of the tibia, and he had been having pain for about 3 months. He had a little bit of narrowing on x-ray. So the MRI showed a stress fracture. So we will treat the stress fracture for 2 to 3 months. And generally with the stress fracture, if the fracture ultimately heals and the joint doesn't collapse down, they don't need, say, a knee replacement. If, on the other hand, after the treatment of the stress fracture leads to an arthritic knee and you'll see changes on x-ray, that's when you would more consider a knee replacement. So if a person has, let's say, a stress fracture, you need to treat the stress fracture first if the x-rays are normal, because the majority of times they're going to get better without a knee replacement. But those are all unique cases, and they're going to really need to see, the doctor's going to need to see the x-ray, see the MRI, treat the patient, follow them along. And that's kind of a team effort between the patient and doctor. But yeah, at the end of the day, there are people who do develop stress fractures, particularly in the femur, which then leads to collapse of the bone, which leads to an arthritic knee, and that may necessitate a knee or surgery. Patients with avascular necrosis of the hip, they can have relatively normal x-rays, and 6 months later, the hip completely collapses. And so conditions like avascular necrosis of the hip, which is not necessarily an arthritic condition, often leads to the need for a hip replacement.
Thank you. Another question, if a person has a full knee replacement on the right knee, typically how long would it be before they can drive?
With the right knee, most of the time, again, how young the patient is, how motivated, but usually by 3 weeks, they could start driving, let's say, to and from physical therapy. By 4 to 6 weeks, they're doing most driving on their own. Everyone's different. You have to be able to be off pain medication before you can drive. You need to make certain you can bend your knee to 80 or 90 degrees. So knee replacements are going to drive typically probably a little less, a little longer. Hip replacements can probably drive a little bit sooner, but the ballpark figure is somewhere between 3 and 4 weeks after surgery.
Right. If you choose to have general anesthesia versus a spinal, can you still do same-day surgery?
You can. We work with really good anesthesiologists. Dr. DePoirier joined us from Houston. He came up here to spearhead this whole program. And article after article after article in the literature supports that the use of spinal anesthetic is significantly beneficial to the patient. It gets the patients up sooner. You have less risk for blood clots. You have less risk of insult to the lungs. So unless a person really has a significant contraindication to spinal anesthetic, the anesthesiologist more likely will recommend spinal. That all literature supports it. Now, if a patient just absolutely says, I don't want spinal and I want general anesthetic, we can do it. The one big advantage of the spinal anesthetic is it takes a couple hours to wear off. And when we inject the expiral into the joints, it sort of takes an hour or two to set up. So if a person has a general anesthetic and they wake up and their legs aren't numb, they may have for the first hour to hour and a half a lot of pain in their joints because that expiral takes a little while to set up. But the answer, no, you could do it under general anesthetic if a person is extremely fearful, but we're trying to provide the safest and the most efficient way of taking care of the patient. And the literature definitely supports the use of spinal anesthetic for joint replacements.
Excellent answer. What about if someone has had gel shots over the past couple of years, would you advise continuing gel shots if that seems to resolve the issue, at least temporarily, or at what point would you consider them a candidate for a replacement?
No, I mean, if you can do the hyaluronic acid injections and for 6 months, a patient can do everything they want to do, I would keep doing that. We talk about doing joint replacements when a person finds that the injections, whether it's cortisone or gel or the anti-inflammatories, are no longer effective and they are unable to do the things in life they want to do. So if a person says, I can get gel shots every 6 months and I can do pretty much everything I want to do, then don't do surgery. Do the gel shots until the patient gets to the point where they say they're not working anymore, or I would like to be able to do more. I'd like to be more active. Basically, we're going to do surgery when a person's quality of life is being affected and the injections and local treatments aren't helping them.
And circling back, you did mention, it touched on hip replacements earlier in the presentation. Are total hips being done in this outpatient setting?
Absolutely. I said all the commercial insurances, Aetna, Blue Cross, they can be done. Medicare at this point has put it on the investigational list. So they're looking at it this year. So if you happen to be 65 or older and have Medicare, you cannot do it at same-day surgery at a surgery center. You could do it at a hospital. Last year, the knees were on the investigational list, and in January, they put them on the okay list. So we anticipate January 1st of 2021 that Medicare will then allow their patients to do it at a surgery center. So hips are done with the commercial patients, the Medicare patients, hopefully by 2021.
This is a question about our surgery centers. We have two, one in Germantown and one in South Haven, Mississippi. Are both surgery centers about the same? What would be are there any differences between them other than location?
The surgery center in the South Haven is a little bit smaller. It has 2 operating rooms and a pain block area, so it's more intimate. The surgery center in Germantown has 6 operating rooms and 1 block room, so it's a little bit bigger. We have 34 doctors in our practice, and probably 2/3 of them practice more out of Germantown, 1/3 of them practice out of South Haven. So they are different. We're remodeling the surgery center at Germantown, so in about 6 months to a year, it's going to be absolutely beautiful. The one in South Haven was remodeled a few years ago, and it's really state of the art. So the surgery center in Germantown is a little bigger, and but the care, anesthesia, we've just got a phenomenal staff. So I think the experience a patient has will be equal no matter which one they go to.
Excellent. A question about both knees. If you need both knees replaced, do you have a recommendation about how long between you go before the second surgery, and whether someone would want to replace, which knee would they want to be replaced first?
Well, I always ask them, does one knee bother you more than another? So if one knee bothers them, do that one first. So if they chicken out on doing the second one, you've got the worst knee done. But generally, the answer is whatever knee bothers them the worst, you do it first. If they say they both bother me the same, I usually recommend doing the left one first. That way they know by the time they get to the right knee, they know what they're in for. But it just facilitates driving. If you do the left knee first, typically within 2 weeks, you can be back driving, and you've got the experience behind you of doing the left knee. So if we do the right knee second, then maybe you can be back driving a little bit sooner and regain your independence. As far as timing, generally 3 months is a good ballpark figure. Some people will do it sooner. Some people do it later. After any major surgery, there's going to be a period of 4 to 6 to 8 weeks where you just don't feel like you have your normal energy. You're not sleeping well. So we really want a patient to get back to their preoperative status of sleeping and feeling good and feeling energetic, and then go back and do the second operation, because you don't want to do it too soon when they don't have a lot of energy and they don't have the ability to participate as much with the second knee. So the general answer is 3 months, but I've had people do it as early as 6 weeks, and waiting later is just up to the patient.
Thank you. And how long could you expect a full knee replacement to last? If someone is in their early to mid 50s, is it likely that they would need another replacement again at a later date?
That's a really good question. And all we can do is look back at literature studies. And if you took 100 people today let's say in 2020, and you operated on a knee or a hip, and we fast forward 15 years, we go to 2035, of the people still alive, because obviously some people will pass away, 90% are doing well. If you fast forward 20 years, 80 to 85% are generally doing well. So the longevity of implants has really improved. I've got a gentleman named Randy. I did him when he was 40 years old. He had a really knee. He is now 60, 20 years out. And he was active in those time. And about a month ago, he came in. He'd ridden his bike 120 miles over the weekend, and he had a sore knee. And his implants still look perfect, like we put them in 20 years ago. So in my practice, it's very rare to revise a knee. So if a person's in their mid-50s, can I tell you with 100% certainty it's going to last a lifetime? No. But at the end of the day, if you can get 20 or 30 good years out of the knee, that's the time to do it now. Why wait till you're 65 and be miserable in pain, hoping that the knee's going to last you a lifetime? I mean, we don't know how long we're going to be here. But the longevity of implants has definitely improved, particularly knees and hips.
We just have a few more questions. One is, how do you control the post-op pain at home?
You know, that obviously that's key. So pain management begins from the time you check in to the time you leave. And Chris Tapori, as mentioned him earlier, he is working on developing a total non-narcotic protocol for total joint replacements. And we're going to start trying this in the next few months. And that's going to be unique and innovative. But currently, when you come into the hospital, we typically are using some long-acting narcotics for 4 or 5 days. That's what I do. You'll get your first dose before surgery. At the time of surgery, I use a medication called Toradol, which is an anti-inflammatory. That's used for 5 days afterwards. And then we combine that with the nerve block that's done by the anesthesiologist. We also inject the Exparel into the knee. So when I talk with the patients that are getting ready to leave the surgery center, I have a list of medications. We use a long-acting narcotic and a Toradol for 5 days. It's a scheduled medication. And then if that works good, that may be all they need for the first 4 or 5 days. If the pain starts to get a little bit worse, then we have conventional pain medicines in addition to that we can use for breakthrough pain medicine. But with the combination of the scheduled medicines, the Exparel, and the nerve blocks, when you talk with these patients, and I think just being home in your own environment helps, they really do well. I give everyone my own cell phone number. And to date, I've never had a person call me and say, I'm just miserable, I think I need to go to the hospital. Sometimes they have to clarify how to take the pain medicine, but of all these patients, and I know I've done at least 150 in the last 4 years, I've never had someone say, I wish I'd have done it in the hospital because my pain was so bad at home.
Awesome. Another question. How many days after surgery can you shower?
Generally, we do, and for me, everyone's different. When we leave the surgery center, you're in a compression wrap. That will stay on for 3 days. So if I do it on a Thursday, on Sunday, we send you home with what's called an Aquacel dressing. An Aquacel dressing is a waterproof dressing. So on Sunday, I have the patients or the family take the dressing off, the compression ACE wrap, and we put the waterproof dressing on Sunday. So basically, from Sunday on after surgery, 3 days after surgery, you're able to shower. We leave that waterproof dressing on for about 5 to 7 days. And so 7 to 10 days afterwards, you take the dressing off. So the answer is 3 days after surgery with the waterproof dressing, you can shower. And then about 7 days later, you don't need to have anything on your knee. You can just shower normally at that point.
Okay, and now I have 3 more questions left. Of course, please feel free to continue sending in questions. Here's one. If a patient has a low white blood count for some reason, would a hip replacement would you recommend a hip replacement or no?
Well, that's a tough question because if a person has a low white blood count, all of our patients that we do surgery on are going to need to see their primary care doctor and get a medical clearance. So if the patient has a low white blood count, you're going to get with their primary care doctor and you're going to ask them, why is this patient's white blood count low? And if even he had to refer it to a hematologist, but you would need to get to the bottom of why their blood count is low and make certain there's no underlying medical condition that could affect their surgery. So it's hard to answer that question unless, let's just say that that's just normal for them. They have a normal white blood count. But obviously, if a person has any kind of medical issues, whether it's a blood issue or heart issue, this all needs to be investigated preoperatively. And when we need to get a clearance from their primary care doctor, it says, yes, I've investigated. She does have, or he has a white blood count that's low, but it's just normal for this patient. There's nothing to worry about. If, on the other hand, he may say, listen, we've worked this patient up and they have an ongoing issue and we won't be able to do surgery. So any type of medical issue would have to be evaluated and looked at and make certain there's no underlying issues that would affect the surgery.
Will the new knee let a patient move and do the same activities as the natural knee?
Well, our hope is that you'll be able to do a whole lot more. Now, it was funny. I had an 80-year-old woman come in about a month ago, and she goes, I really wanted a 20-year-old knee, and mine still feels 80. And I said, well, does it hurt? No. Can you walk? Yeah, I'm walking 2 miles a day. She goes, but I just wanted it to feel younger. It was funny. But if a person has no pain and they can walk and they can exercise, they generally can do way more than they could do before surgery. But I'll tell patients, it's still, your body's still 60 or 70 years old. I had a lady who I knew because her husband was my dog's vet, and she went water skiing. She was in her 70s after a year after surgery, and she did great. So generally, if we can give you a hip or knee or shoulder that doesn't hurt, you'll be able to do more things than you could do before surgery.
And Dr. Krahn, you mentioned in the presentation CPM. Can you explain what that is and what it does?
A CPM machine is just a machine that goes to your house or it's in a hospital, and it's called a continuous passive motion machine. So it allows us to put your knee in this machine, and it just for 2 hours at a time, typically 2 or 3 times a day, so 4 to 6 hours while you're laying in bed, it moves your knee for you. It passively is when a machine is doing it. So just kind of like an automatic bicycle. You're laying down, your knee's moving up and down, and it just helps promote motion in the knee. And it also, by moving your knee, helps prevent blood clots. So it's just a way of us doing some physical therapy while you're at home when you're not working with a physical therapist.
This is our last question that we have. How often is physical therapy after knee replacement?
Generally, therapy after knee replacement is going to be 3 times a week for about 4 to 6 weeks. The goal of therapy initially is just getting them to walk and start bending their knee. Then you focus more on strength and conditioning. And so we work with the therapist, and they may say, hey, listen, at 4 weeks, this patient's good to go. They're walking, their strength is good, and we're going to put them on a home exercise program. Sometimes the therapist will say, listen, they're doing good, but we need to work with them another 2 to 4 weeks. So the ballpark figure is somewhere between 4 and 6 weeks you're working with the therapy. And then by 6 weeks, most people are transitioning to a home exercise program.
Excellent. And one more question came in. We're going to make this the last one, and then we'll proceed from there. Are there exercises that one can do pre-surgery to help?
Yeah, I mean, there's no question. The more you can lose weight, the more you can walk, whether it's bicycle, walking outside. I mean, I realize with an arthritic joint, your activities are limited because of pain and discomfort, but a stationary bicycle or elliptical to take the pressure off, doing some lightweight leg extensions can help. Anything you can do to keep the movement of your knee, keep your knee moving well, keep your weight down, it really helps you after surgery. Some patients will actually set up some therapy beforehand. A lot of it depends on the insurance companies because they may have a limited number of therapy visits afterwards. But anything a person can do to keep themselves in what I'd say better shape, they're going to do better after surgery.
Dr. Krahn, thank you so much. Do you have any parting words for everyone before we adjourn?
No, again, thanks for coming. This has been a fun challenge. Dr. Patterson and I started this about 4 years ago, and we went from 2 of us to we've got a fantastic team at Ortho South, and from the anesthesiologist to the Marcia, we got all these nurses that are really focused on our joint replacement patients. So our hope is if you have an interest, talk with one of the doctors. I think as you go through this, you'll really appreciate how working with a group of dedicated people who focus on taking care of patients on an outpatient basis, that your experience will be so much better than going into the hospital. But if you happen to meet with the doctor or you happen to talk with Marcia, and Marcia just says, listen, I think we need to do it in the hospital. We're not saying don't do the surgery. we're at times a little bit conservative, so don't get too disappointed. But most of our patients, we can do same-day surgery. But whether you do it in the hospital, whether you do it with us at our surgery centers, I can tell you the doctors of Ortho South will take great care of you, and the staff around us will take great care of you. And I think you'll be pleased with what we've been able to help you with.
Excellent. Well, just as a final note, again, thank you, Dr. Krahn, for your time today. Thank you, all of our participants who came in and asked these really excellent questions for your time and your interest. And if you have any other questions, please do not hesitate to call us, make an appointment with us. You can find us online at orthosouth.org and email us. Our goal is to be here for you when and where you need us and however you need us. So again, thank you, everyone. And with that, we'll adjourn.
Thanks, Melissa. Great job.
Thank you.